Thank you, Dr. Mukesh, for this opportunity, and thank you, AIOS. I'll be talking to you about starting PHAKIC IOLs in private practice. So, what are the investigations and what is the type of patient selection that you want to do in PHAKIC IOL surgery? So, to begin with, we already know that there are different types of PHAKIC IOLs. The older version was anterior, as well as now there is posterior. Anterior chamber IOLs are not much in use, the reason being that they lie anterior to the iris. So, because of which, apart from the huge cosmetic blemish, they also can have a lot of chances of corneal endothelial touch, which can lead to decompensation. The main advantages of posterior chamber PHAKIC IOLs are they lie behind the iris, so they are far from the endothelium, they have excellent cosmesis, they are close to the nodal points of the eye, so they actually give a far superior quality of vision to the patient than any other procedure. There is also a gain in the retinal image size, again because it is closer to the nodal point, and there is a greater effective optical zone. Because they are sulcus located, the most important advantage is that they are stable, easily removable or exchangeable, no fixation to any tissue, and it does not alter the shape as any refractive procedure will do. So currently you have a couple of options. You have the Star Surgical, which is the Vision ICL, you have the Care Group, which is the IPCL, you have ICRL, and you also have RIL from Appaswamy. The indications, the first and most important indication which you should know of is the age, of course. Now, on paper, the age is 18 years, but preferably because this is a surgical intervention where you enter the eye, you would want to voluntarily tell them that we would like to wait till the age of 21. You have to have a documented stable refraction for at least 1 year, and you need to inform that to the patient. There is a lot of them who will come and say, no, let us do it anyways, I've had number, etc. Patients who are not suitable for corneal refractive surgery anyways, they come to you for PHAKIC IOL because they have not been eligible for LASIK or the number is too high. The most important prerequisite would be AC depth more than 2.8 millimeters in myopia and 3 in hyperopia. Endothelial cell count needs to be good and no other ocular pathology. So your contraindications would be any ocular pathology starting from the cornea, corneal dystrophy or endothelial cell count less than 2000. AC depth, if it is not adequate, you can't put in a PHAKIC IOL. If there is any history of uveitis, any presence of anterior chamber or anterior or posterior synechia, then you want to abstain from doing such a lens. Glaucoma, even if you are slightly suspecting it, you would want to avoid. Evidence of nuclear sclerosis, of course, you want to avoid because you'd rather remove the lens itself. And any personal or family history of retinal detachment. This is important because there are studies that show that the risk of RDs increase after you have entered with a PHAKIC IOL in very high myope patients. So what do we check? Everything. Don't leave anything. Starting with visual acuity and refraction, you need to do a dilated refraction as well. AC depth from endothelium, your iris configuration, your axial length. So you would want to do an optical A scan, which also gives you the lens thickness like lens star. Dilated evaluation, check for the crystalline lens. Does it have any phacodonesis? Are the zonules okay? Is there any zonular weakness? Check the angles. Do a proper gonioscopy to evaluate the angles. You can also do an ASOCT to check what is the anterior chamber status. Glaucoma has to be vigilantly checked for. You need to check your IOP by applanation. You need to check white to white, which I'll be talking about. You need to do your pupillometry and a detailed retina checkup. Now, in this retina checkup, don't do a regular retina checkup on the slit lamp. Get a proper retina specialist to do an IO with indentation so that you have gotten retina clearance. Ultimately, in this procedure, we are entering the eye, so you want to make sure everything is a 10 on 10 before you operate. So coming to refraction, do a cycloplegic refraction. Make sure that you have documented stability. These cases are more difficult in keratoconus and post-LASIK ectasias and post-RK. Get a specular done. Let the patient know that yes, we are doing these additional investigations, not just randomly, but because this has to be safe for the rest of your life. So a lot of them get demotivated because there's extra tests that you need to do, but you need to emphasize on the importance of that. So endothelial cell count should be done, and minimum cell count of 2000 is okay. Now, anterior chamber depth, you can check this in various ways. Clinically is not okay. You will need to do a objective assessment. So you can get that on your ultrasound A scan, you can get that on an optical A scan. tomography or OCT. So usually if you have done an IOL master or any optical A scan, there will be a display which shows you what the AC depth is. For example, in this case it is 4.03. In a topography, if you have, then again the topography will show you what the anterior chamber depth is. And what is more important is that you should know in that machine whether it is showing you the AC depth from endothelium or epithelium, because you need to know the AC depth from endothelium. Coming to white to white measurements, again, you can do it with the digital calipers. You also can get your measurements on optical A scans. You can also get it from tomography like pentacam and OB scan. And autoref also sometimes gives you white to white measurement. What is most important is this particular measurement, the most important determinant for your appropriate phakic IOL sizing. Manual is the best method, but there is a high inter-observer variability. You need to order a digital calipers, which we'll be showing you in the video that follows, and parallax has to be considered. What you need to do is, you need to take the reading from the mid limbus to the opposite side mid limbus, not the outer, not the inner, middle of the limbus. And what you need to do is, you need to take 3 readings so that you can send them for the sizing. So you should not be using regular manual calipers, because you will need a digital one. You also get very good white to white measurements on the OB scan, but the availability of the OB scan currently is a little tricky. For the white to white measurement, this is a small video to show how it should be taken. Under topical anesthesia, you take your digital calipers. As you can see, we go from mid limbus of one side to diagonally opposite mid limbus. It's very important that you explain this additional procedure also to the patient, because ultimately you are adding one procedure apart from the investigations. You are going to take him into OT, do this, and then order. So again, more intervention. This will show you your digital reading. You will take 3 such readings, because whatever phakic IOL you are using, they will ask you for multiple readings of optical A scan, of topography, as well of white to white. So each of the phakic IOL sizing is based on the combination of these factors, the white to white as well as the AC depth. You can also do a UBM pre-op analysis. We used to do this regularly when we were back when we were fellows, because it gives you a good sulcus to sulcus measurement. You also get to check the anterior lens rise, which is the crystalline lens rise, which is the distance between the anterior pole of the crystalline lens and the line that connects the 3 and 9 o'clock angle recess. Now, in the vault, which is something that you are going to check post your surgery, okay, this you need to check mandatorily for everyone to know whether your phakic IOL patient is stable or not. You need to check the distance between the center of the posterior aspect of your ICL and the anterior pole of your lens, okay. The ideal volt would be anywhere between 300 to 900. So to summarize, you need to have proper selection of the patient. You need to do a good counseling of the patient to tell them all the things that we just spoke about. One is the number of investigations, one is the additional procedure for white to white, and ultimately the fact that you are now entering the eye to do a phakic IOL and comes with its own risks, which we will be further talking about. You need to take accurate measurements, so don't compromise on doing manual measurements versus optical scans. Proper counseling is very important, and it is also important to have trained staff to help you with all this. But the ideal thing that you should remember is, for these patients, because they are not going to come as in volumes as much as your other patients, make sure that you step in and take these measurements yourself if possible. Thank you very much.